Bismillah ar-Rahman ar-Rahim, Thrombolysis and Devices in Acute Limb Ischemia by Mr. Muhammad Omar Al-Farouk. The learning objective of the following presentation will be the importance of guidelines and how it is rapidly evolving in peripheral vascular disease, the new digital teaching platform, how we can deal with an acute ischemia, and the take-home message. The peripheral vascular guidelines have rapidly changing from Task 1 at 2003 to Task 2, which was mainly Transatlantic Society of Vascular Surgeons of Europe and United States. Then the European Society of Cardiologists have issued a guideline for peripheral vascular disease at 2011. Then two very big cardiology society, which are the American Heart Association and American College of Cardiology, developed a peripheral guideline at 2016. Now both cardiologists and the surgeon have made the ESCVS 2017 guidelines, which are fantastic. And we have at 2018 a new guidelines, which also was a combination of effort of cardiologists and the vascular surgeon of many society, and these are the current global vascular guidelines in the management of critical limb threatening ischemia. This is the European Society of Cardiology guideline at 2011, which was a good effort, but no recommendation to read it at the moment. In 2016, these are the effort of the two biggest heart association in the United States on peripheral vascular disease. Now this is 2017 European Society of Cardiology with the European Society of Vascular Surgery combined effort. It's a great guideline recommended to be read by everyone. And I will put it on the digital teaching platform, the slides and the document itself for references. How a guideline is being performed. There is a team, which is a committee. A huge committee will collect all evidence-based medicine data. And after collection of all this data, they will have the final recommendation according to these current data. It's a very valuable tool for clinical management of our patients. At 2018, we have the Global Vascular Guidelines, which I will also include in the digital platform for references. Now the language have changed with the class of recommendation. We used to have 3 classes of recommendation, 1, 2, and 3. Now the class 2 is divided into moderate and weak according to the recommendation, and class 3 also divided into 2. Class 3 no benefit and class 3 harm. So you can see the language have changed. Now the quality of evidence have also changed. We used to have level A, B, and C. Level A stayed the same, but level B is divided into 2, which are randomized and non-randomized. And we have level C of evidence divided into 2, either limited data or expert opinion, which call level C LD and level C EO. Here is a summary of the level of evidence to explain what each one of them means. Now, this is the scope of the guidelines regarding peripheral vascular disease. You can see it did not speak about the aortic aneurysm, so there is no guidelines from the European Society of Cardiology in this regard, but there are guidelines from the European Society of Vascular Surgery. But they spoke about the mesenteric vascular ischemia We spoke about renal artery disease, lower limb extremity, cerebrovascular disease, and upper limb ischemia as well. And this is a quite broad spectrum to cover. Now, regarding the classes or recommendation, you can see nearly 50% of the recommendation were actually grade 1 and grade 3, and this is clear what to do. Do 1, don't do 3. But also 50% it was between 2A and 2B, which are the vague area for the decision making. Please note that task now is a history. There is no mentioning of task anymore. It become history, and now the critical limb ischemia is now called critical limb threatening ischemia, and this is very important to remember. Definition. Now, acute limb ischemia occur when there is a sudden lack of blood flow to a limb, to the degree that the limb viability will be lost. That is why timing of diagnosis is crucial, and the first 6 to 12 hours from the onset of diagnosis can have a drastic difference in management. It can be caused by embolism or thrombosis, and these are the commonest two causes, but also can happen by dissection and trauma in some event. And this is very important to define the acute ischemia, as we know by the 6 P's, which are very important. Now, there are two big group of causes, which are the embolus or thrombosis. And you can see here, embolus can happen from either cardiac source, which are 75% from atrial fibrillation. It also can happen from a throma in the artery, like the Bluetooth syndrome with aortic aneurysm. It also can happen with paradoxical emboli. And this is very important to know these causes to diagnose the patient quickly. They are sudden onset, and usually the contralateral limb are normal with normal distal pulses. Usually the embolus will be at the bifurcation of the blood vessel. It usually stops as a common femoral artery or popliteal artery to prevent the blood from flowing. Now, this is rarely seen. We don't see embolus much more after management of rheumatic heart. But we see more and more thrombosis. These are common. You see in a lot of critical patients from atherosclerosis, hypercapillary state, hypovolemia, trauma, previous bypass, or atherogenic. And this is what is common for you to see. And this is very important to differentiate between the embolus and the thrombosis. Now, treatment is very important to, number one, diagnose quickly, and then to start giving intravenous heparin as a bolus dose. Give the patient oxygen even though he might not have respiratory disease, to improve oxygenation to maintain viability of the limb. Start by immediate analgesia, because this is extremely painful condition. You can give 1 or 2 milligrams of morphine. Start putting Foley catheter, because this patient will have a procedure soon. Start intravenous fluid to keep the patient dehydrated. And I would use intravenous prostaglandin E2, one of the very strong prostaglandin, which is very strong vasodilator, but this is not in the recommendation or in the guidelines. This is just from personal experience. And then you plan for an urgency duplex followed by CT angiogram. You need to have a unit which have 24-hour service of duplex and CT angiogram. This patient cannot wait for the next day. Now, in this slide, I've put the management regarding the endovascular treatment. And this is by Sage Open Medicine 2013, which I think is still valid up till now. You need to have an angiographic evaluation of an inflow and outflow. Duplex only, I think, is not recommended in acute ischemia. Now, one of the very important percutaneous aspiration catheter is called Penumbra catheter, but unfortunately it's not found in Egypt. But this is one of the catheters that's really very flexible and very soft and can be used. Now we're going to discuss the percutaneous mechanical thrombectomy devices like the Angiojet, and we're also going to discuss the thrombolytic catheter like fountain catheter. I think excimer laser are not found in a lot of centers, so this will be theoretical. I wouldn't think we need to speak about it. And also we need to assess the guide wire test, passing guide wire through this soft occlusion, especially in acute on top of chronic, and we'll use a multiple side hole catheter like the fountain catheter. So these are the endovascular treatment for acute ischemia, which if the hospital have the facility, definitely it offer an advantage to the patient. Now let us discuss Penumbra catheter. Penumbra catheter is not found in Egypt, but I think it will be soon available in the Egyptian market with the new year. The price of a single catheter is around €2,000. It's mainly done intracranial. You can see the catheter, which is Cat 8, going into the arch, going to the common carotid artery. It's a very flexible system and very atraumatized system. It can follow the internal carotid artery to middle cerebral artery, and you can retrieve any thrombi. It is mainly on 0.014 platform. In many places, it has been used in arteries and in veins of the lower limb, and also used in coronary circulation. I will leave you with this demo to show how flexible it is. It's a computerized demonstration of how the system works. You cross the fresh thrombus with the guide wire, 0.014 specific guide wire with the Penumbra device. Then you put the device at the proximal end of the thrombus, and then you connect it to the aspiration tube, and then you start suction. This is very, very soft suction pump, and it has have FDA approval to be used intracranial and in lower limb arteries and lower limb veins. And this is the demonstration of how the technique works and how it takes the thrombus out. And after the thrombus is being retrieved into the tubing, then you will restore the blood flow. And it's an ideal for intracerebral circulation.
There is a barcode here, so you drop it in like that, okay? And then make sure that only this one goes in, right? And then facing out, and then you spike your heparin saline. So put in, if you have a 500 ml of saline, put in 2005 units of heparin. If you have a bigger, like 1 liter saline, you put in 5,000 units of heparin. So you just half it, okay? Then once you spike it, all right, you can. There is a barcode here, so you drop it in like that, okay? And then make sure that only this one goes in, all right? And then facing out, and then you spike your heparin saline. So put in, if you have a 500 ml of saline, put in 2005 units of heparin. If you have a bigger, like 1 liter saline, you put in 5,000 units of heparin. So you just half it, okay? Then once you spike it, all right, you can close.
Okay. So it will automatically remove everything.
Yes, because there's a bubble detector and also a pressure detector inside. So not to worry if you see any bubbles here.
So you don't have to put in syringe or everything.
No need. You need to prime it now. So now once your doctor has actually holding on to your catheter and your pump is being dropped inside close, you see that there is a negative seconds here. So this will tell you you have to flush it for 15 seconds. It will count down for you.
Now let us discuss Rotarex SC catheter by Straub Medical. It's a very common catheter used in Europe for peripheral arterial and venous intervention. It's found in Egypt of the price of 30,000 Egyptian pound. You can see here a demonstration of how the catheter works on a demo. It's a machine which rotate and have a continuous negative suction. It's on top of 0.035 guide wire, so can be used in superficial femoral artery, and it rotates. You always worry when you have a patient with previous stenting that this machine might damage part of the stent. So be very, very careful when you are doing this case for an occluded SFA with a stenting. You can see it have a continuous suction. It starts suction proximal to distal, so the distal will act like embolization plug to prevent the distal embolization. And then when you hear the machine, suddenly there is a change of voice which will show that you have crossed occlusion, and the movement of the catheter will dramatically change, and you will have a continuous suction of blood. This is where you need to stop the machine and to have assessment with an angiogram.
Merit Medical offers a comprehensive line of catheter-directed thrombolysis products. An exceptional benefit derived from the fountain infusion catheter is its ability to deliver thrombolytic agents and attack the entire clot uniformly, with high-pressure jets of lytic agents as compared to current competitive catheters. The fountain infusion catheter has side ports which rotate circumferentially around the catheter and course the entire length of the infusion segment, providing a uniform dispersion of the agent within the thrombus. Other competitive catheters have side holes or slits, which may not be distributed around the circumference of the device and may result in disbursement voids. Optimal thrombolysis can be achieved with either the 4 or 5 French fountain infusion catheters. And when adding the Merit Medical squirt fluid dispensing system, a more consistent and forceful pulse injection can be achieved over the competition. Merit Medical offers a comprehensive line of catheter-directed thrombolysis products. An exceptional benefit derived from the fountain infusion catheter is its ability to deliver thrombolytic agents and attack the entire clot uniformly, with high-pressure jets of lytic agents as compared to current competitive catheters. The fountain infusion catheter has side ports which rotate circumferentially around the catheter and course the entire length of the infusion segment, providing a uniform dispersion of the agent within the thrombus. Other competitive catheters have side holes or slits, which may not be distributed around the circumference of the device and may result in disbursement voids. Optimal thrombolysis can be achieved with either the 4 or 5 French fountain infusion catheters. And when adding the Merit Medical squirt fluid dispensing system, a more consistent and forceful pulse injection can be achieved over the competition. Both foreign
Echos Corporation, a BTG International Group company, offers a minimally invasive endovascular treatment to gently and completely dissolve thrombus and restore blood flow while reducing the risk of complications. At Echos, our products are designed to treat smarter and achieve more. Here's how it works. When an obstruction such as atherosclerotic plaque interferes with blood flow, a clot may begin to form. Over time, the clot or thrombus increases in length and blocks more and more of the vessel. As the clot forms, plasminogen is incorporated into the fibrin. In order to dissolve the clot, lytic agents must reach the receptor sites on the plasminogen. The Echosonic endovascular system facilitates this process. It simultaneously delivers both the lytic drug and ultrasound energy to the clot. Together, they quickly dissolve the clot and restore blood flow, without causing hemolysis or vessel and valve damage. Advance the echosonic infusion catheter over the guide wire and across the treatment site. Note that radiopaque marker bands at each end enhance catheter visibility. Remove the guide wire and the infusion catheter is ready to receive the ultrasonic core. Gently insert the ultrasonic core within the treatment zone of the infusion catheter until the luer fittings can be locked. The echosonic Echos Corporation, a BTG International Group company, offers a minimally invasive endovascular treatment to gently and completely dissolve thrombus and restore blood flow while reducing the risk of complications. At Echos, our products are designed to treat smarter and achieve more. Here's how it works. When an obstruction such as atherosclerotic plaque interferes with blood flow, a clot may begin to form. Over time, the clot or thrombus increases in length and blocks more and more of the vessel. As the clot forms, plasminogen is incorporated into the fibrin. In order to dissolve the clot, lytic agents must reach the receptor sites on the plasminogen. The echosonic endovascular system facilitates this process. It simultaneously delivers both the lytic drug and ultrasound energy to the clot. Together, they quickly dissolve the clot and restore blood flow, without causing hemolysis or vessel and valve damage. Advance the echosonic infusion catheter over the guide wire and across the treatment site. Note that radiopaque marker bands at each end enhance catheter visibility. Remove the guide wire and the infusion catheter is ready to receive the ultrasonic core. Gently insert the ultrasonic core within the treatment zone of the infusion catheter until the luer fittings can be locked. The echosonic endovascular system
Now the embolectomy catheter, you can see this is the case of tracheal artery embolectomy. You open small arteriotomy below the knee, and you can see the thrombus starting to appear. You have a proximal distal control to the artery, and then you put an embolectomy Fogarty catheter designed by Thomas Fogarty, 1864, when he was a fourth-year medical student. All the Fogarty nowadays are on top of a guide wire. This is an old Fogarty catheter. And then you pass above the occlusion, inflate the balloon gently, and then take the blood flow out. Be very careful, this is a very dangerous tool, and you can very easily injure the engine. So be very, very gentle when you are taking this embolus out. Now, regarding catheter-directed thrombolysis, I wouldn't recommend at all using streptokinase or urokinase, only RTPA, recombinant tissue plasminogen activator, in the dose of 0.5 to 1 milligram per hour. This will reduce endothelial damage. I recommend using the pulse spray technique with fountain catheter on a specific lens to be intralesional. You have very carefully to exclude contraindication to thrombolysis. Try to avoid having a second ampoule of thrombolytic therapy, and you have always to admit the patient to intensive care unit. And this is the technique of intraarterial thrombolysis. In this slide, I have mentioned the contraindication for thrombolysis that you have to review in every case. Avoid patient with GIT bleed, recent cerebrovascular accident the last 3 months, recent head injury or head surgery, recent eye surgery, or diabetic background retinopathy, bleeding tendency, hepatic failure. You have to be very, very careful before starting thrombolysis. Now, this is an important slide regarding the clinical category of acute lymph ischemia. It's divided into 3 grades, 1, 2, and 3, and grade 2 is divided into 2A and B. You have to remember the grade 3 is a major tissue loss, permanent nerve damage, and you don't hear any venous signal, and usually patients have profound sensory loss and profound motor weakness. You have always to consult your colleague in order to know which stage the patient is at, and this is very important clinical experience. Now, from the guidelines, here are 3 very important recommendations. All of them are class 1 and level of evidence C, but they are very important. Number 1, in case of neurological deficit, urgent revascularization is indicated. No question about that. In absence of neurological deficit, revascularization indicated within hours. Number 3, heparin and analgesia are indicated as soon as possible. Another very important slide regarding the management. We all agree about the initial management of full anticoagulation and pain management, and then the patient will be divided into 3 groups after that. Either the patient have a viable limb, and in this case you can go to a CT angiogram and assessment and management, or patient is viable with neurological deficit, then you don't have any time to waste, and in that case you need urgent revascularization, either thrombectomy or bypass, or you can use the tool that you have available, Angiojet or Rotarex at your hospital. Now, irreversible damage, and this is very important, no arterial, no venous, and venous signal, there is total motor loss, total paralysis, it's a dead loss or a dead limb, and then you have to go for amputation and level of amputation according to the clinical condition. Now, this is a continuation of the sheet regarding the management. If you're able to discover the offending lesion, if this is an acute on top of chronic, like critical stenosis, SFA, or common femoral or iliac, then you have to try to deal with the offending lesion, either by endovascular option or by open surgery. Now, one of the important mobile applications that I would recommend you to install in your mobile is the European Society Pocket Guideline application, and there is a peripheral section where you can have all the recent guidelines updated into your mobile application. Now, I have created a vascular training program on a digital platform by Google Classroom, where you are able to access if you enter the following code on this slide. And with this code, you will find a lot of books and a lot of videos, and you'll find this lecture as well, and with question and answer. And I wish you a very nice and fruitful future in vascular surgery. So to conclude, my conclusion that not every hospital should be accepting acute limb ischemia. There is prerequisition, 24-hour CT angiogram, 24-hour team, and 24-hour duplex scan with a facility to manage these cases. Still, they have very bad prognosis. The 1 month mortality is still up to 30%, and the amputation rate is very high. New technology definitely will keep changing, but the important question is which facility or which instrument and tool that my unit should have at this scenario. That is why I've put the platform of the multiple tools available and my recommendation which one is better. And let me finish with this sentence from Gracie Allen. He said, each of us has been put on earth with the ability to do something well. We cheat ourselves and the world if we don't use this ability to the best we can. And I wish you all the best. And thank you very much with all my best wishes.